this paper was written in the British Journal of Cancer in order to review all the current modern radiotherapy techniques, including whole breast radiotherapy techniques, partial breast radiation techniques, as well as the idea that we may decide not to give any radiotherapy to patients at all. Now, I'll come to the last point first. What has been shown in several trials is that at 5 years, the recurrence rate with no radiotherapy, even in the best prognosis patients, is about 4% or 5%, compared with about 1% with radiotherapy. Now, at 10 years, the PRIME-2 study was presented in San Antonio, and they found a 9.8% local recurrence rate with giving no radiotherapy. And remember, these were patients which were highly selected. They were older patients, over 65. They had to be grade 1 or 2. They had to be node negative with clear margins. They had to be ER positive. So they were the best prognosis patients. But despite that, not giving radiotherapy led to about 10% local recurrence rate. And now they said, and the part is what is important here is not only that there is a 10% local recurrence rate, but the benefit of avoiding scattered radiation was not seen. That is perhaps because in their study, they found that the breast cancer deaths, if you look at the non-breast cancer deaths and breast cancer deaths, they seem to counteract each other. So there seem to be fewer non-breast cancer deaths in patients who have no radiotherapy, but slightly more breast cancer deaths, perhaps because of the increased local recurrence rate. And they seem to cancel out each other. So there is no survival benefit of avoiding the scattered radiation. So my point is that by not giving radiation, you're getting some benefit, but you're taking away the benefit because you cause more local recurrence rate. If you gave intraoperative radiation during the lumpectomy procedure itself to these patients, they would have the benefit of having the low recurrence rate because of effective radiation, at the same time avoid scattered radiation, so get the benefit of not increasing breast cancer mortality, therefore showing the improved survival that we found in the TARGIT-A trial. So no radiotherapy, I do not think is a good idea because these patients do live for 20 years, 10 years. 80% of these patients live for 10 years, and they had a 10% recurrence rate. So you don't want every 10th of my patient to go back to surgery within the first 5 to 10 years of their life when they're more frail. They're older than what they were before. So that's about no radiotherapy. What about the 5-day fast-forward regimen? The 5-day fast-forward regimen was given with a much higher dose of radiation per fraction. And it radiates the whole breast, which I think is a bit backward step because we are trying to focus treatments to the most important area and try to avoid surrounding scatter and harm to other organs. So firstly, it gives radiation to the whole breast. There is no avoidance of scattered radiation. There was no reduction in mortality in any form compared with the 3 weeks of radiotherapy. And they reported that the fibrosis, the hardening of the breast that the patient felt, and the clinicians could assess by clinician assessment, was 19 times more from the view of the clinician, and a quarter of patients complained of hardened and firm breast. Now, that is quite a large proportion of patients having this symptom, which doesn't go away. And this was only at 5 years, and usually will get worse with time. So I'm very concerned about using this treatment as standard of care of giving 5 days of whole breast radiotherapy. We also then compared with other forms of partial breast radiation, which involve external beam radiation. For example, in the RAPID trial from Canada, it still involves several days of treatment, multiple visits to radiotherapy departments, and the cosmetic outcome is much worse than standard radiotherapy. So that is what was reported in the large RAPID trial. The NACBP has not yet reported it. And the other form of partial breast radiation is brachytherapy, which does involve having the patient admitted, having put wires in the breast with multiple wires going through the breast. And if you show the patient the photograph, this is what we're going to do to you. I don't think patients will want it. Their control was good, but it could leave scars at the place of the wires are there. And it does involve quite significant resources. And even though brachytherapy is localized, there is still scattered radiation, and they didn't report any improvement in or reduction in mortality from other causes or from breast cancer. So I was looking for this because of patients who were really keen on having partial breast radiation. What are the options they might have? The import low trial found good results. So that partial breast radiation only localized to the primary area, primary tumor is good, but patients still have to go for radiation every day for 3 weeks if you follow the proper protocol of import low trial. So trying to give import low trial in 5 days is not proven. But that is it, and it's not correct to give import low protocol of partial radiation or just over the course of 5 days, just because by combining fast forward and import low protocols. That has not been proven, and I don't think it is appropriate to do that. So although you may say I'm biased, but it is clear from TARGIT-A trial that giving radiation during lumpectomy seems like a no-brainer and patients love it. It's convenient, and various patient preference studies from Australia, from US have shown that they prefer this, even though there might have been increased recurrence risk. That is not there now. And the latest study from the US West Coast of America, the Kaiser Permanente group, patients are given a choice of having whole breast radiation, no radiation, or intraoperative radiation with TARGIT-IORT, intrabeam technique. And 75% of the patients chose to have TARGIT-IORT. A very small proportion chose a mastectomy. A very small proportion chose no radiation or whole breast radiation. So patients prefer to use TARGIT-IORT, and we should listen to patients because, after all, whatever we do is for the benefit of patients. The quirk of the whole matter is, and this was brought up by the editor of the Red Journal, he wrote an editorial in which he said that TARGIT-IORT intraoperative radiation could be considered a quantum leap forward or a serious threat, because if the payment model is such that you're paid per fraction, so number of visits to the hospital times the X is the payment, then the physicians would be paid something like $2,000 to $3,000 in the US, compared with only $900 or $800 if they give intraoperative radiation during the operation. So that should not be an incentive to make patients have this treatment. Now, one center in India has has treated this problem very well. Is that whatever the treatment of radiation the patients get, the patients pay the same amount of money, the hospital makes the same amount of money. So which treatment they get, whether they get whole breast radiotherapy over a course of 3 weeks or a single dose during operation, the patient pays the same amount of money, hospital gets the same amount of money, doctors get the same amount of money, but the patient gets a big convenience of finishing the treatment, as well as benefits in terms of quality of life and benefit in terms of survival. And that is the way forward. I think we should not have any other financial incentives for giving more radiation to patients.